Our next speaker is Dr. Bruce Schirmer, past president of the SAGES and a real leader in American surgery, particularly with the ACS Bariatric program. We've asked him to speak about his experience with leaks with gastric bypass.
Well, thank you, Dan. Thank you for Dan and Merle for inviting me and recognizing my vast experience with complications. I think that it's not a great reputation, but what the heck. In any case, so greetings from Virginia. This is a view of where I live. My disclosures, I have been treating complications for 27 years now. And very briefly, we'll talk about two things, though. This is going to be about leaks after bypass and about stenosis after bypass. So leaks are the second leading cause of death after PE for patients who have gastric bypass. They can present in a variety of ways, and most concerningly, they can be insidious. You have to have a high index of suspicion. So there's going to be two or three major points about this talk. One is that if you think they've got a leak, you got to treat them like they've got a leak. So if it even crosses your mind, think about leak and take the appropriate action. And you have to do these things rapidly. You can't be thinking about it. And like I always tell my residents, if a patient doesn't look good after you've operated on them, it's not because God made it that way. It's because of what you did, and you got to go fix it. So some leaks are very obvious, but they all can be deadly if ignored. And if they're insidious and you miss them, then the patients get pretty sick. And sometimes they happen after the patients go home. So if the patient calls you and starts giving you some symptoms over the phone, you have to perk up your ears and get your antennas up and make sure you get them in to get looked at appropriately. There are several etiologies. The early ones are usually almost always technical. You didn't quite get the stapler right, didn't sew it closed right, whatever. Later ones can be of other processes, ischemia, obstruction, and so forth. The most highly concerning symptoms are pretty obvious, and the patient looks real sick. They got a fever, they got tachycardia, they don't feel well, they got white count. A lot of times you may look at them and think they've got a PE. Anytime you're evaluating a bariatric patient in the early postoperative period and you think they've got a PE, you also have to think they might have a leak as well, because the two are sometimes very clinically similar in terms of how they present. If a patient tells you they're going to die, you better be careful that they don't. Mild dyspnea and mild tachycardia alone can be the only signs that present in some patients. In 20–25% of patients in some studies, that's the only sign you see. Oliguria and decreased fluid output, increased fluid requirement, or rather decreased urine output, are certainly also present with third spacing, obviously, from the inflammatory process. So if they have a less concerning picture, just maybe some tachycardia, you're not quite sure, you have to really observe them carefully, follow their vital signs, get some labs, get some films, maybe get a swallow study, maybe get a CT. More concerning picture, however, you certainly want to get those investigations rapidly, and if they start to deteriorate at all, you operate on them. Most concerning findings are an obstruction picture, because if they get obstruction, things are going to start blowing open and you got to get it fixed. Distal gastric distension is your biggest enemy in a gastric bypass, because you can't see that lower staple line. And if the stomach gets big and blows out, you'll never know it from any studies that you can do until they get sick almost to death on you. CT scan showing free fluid in the abdominal cavity is greatly worrisome. A left pleural effusion is worrisome. And a swallow study can show a leak but may not. So this is an example of a CT with, you see there's a lot of fluid around the spleen. This patient had an obvious leak. The site of the leaks are important. So if you've got a leak up top in the proximal anastomosis, you're going to see that with your study most of the time. Now you might miss them. The small ones you can miss, but there the swallow study is helpful. But it's the other areas that you're not going to see. Your distal stomach line you can't see, you can't test it, and your distal anastomosis you'll not see because the contrast is not going to get down there in enough concentration to tell you anything. So again, shown here. So these, anything that's in this staple line here or down here, it's hard to test for those, and you have to have a high index of suspicion if you've got a leak in those areas. This is an obvious leak from the proximal anastomosis. Oftentimes the leak comes from the actual pouch, not the anastomosis itself. In the literature, the highest instance is from the anastomosis, second highest from the pouch, and the third highest from the distal stomach line, and fourth highest from the distal anastomosis. So how good are swallow studies? Well, they're okay, but there are some studies that have shown that they're pretty inaccurate. And again, that I think begins on technique. It depends on where the leak is, and so they're never going to pick up all of them just because not all the leaks come in areas that can be seen. So if you still have a patient, even after the studies are okay, that doesn't do well, you have to take them to the OR. I mean, I just think you have to follow that dictum. Obstruction is, again, as I said before, a real enemy. If you get stenosis of the distal anastomosis, that's a real problem. And when I'm doing these operations, I personally think that I do not want to screw up the distal anastomosis, because making a problem there, causing an obstruction there, can lead to real problems, because you've got no outlet for your distal stomach, and it's going to distend and it's going to blow open. So if they get distension, if they get complaining of left upper quadrant pain, I mean, there's really, if you block this here, this is a closed system. And where it's going to give way is right here on these staple lines. So it's an example of a patient who did have a distal obstruction right at the end of enterostomy. And what you see is a picture like that on the swallow study. And actually, that's why I still get swallow studies. I still get routine post-op day 1 swallow studies. I rarely pick up leaks that I don't suspect clinically, but I do pick up early obstruction in these patients, and I have taken several patients to the OR in the last few years that I didn't have to worry about the stomach being too distended. I got there before it got that bad. This is what it'll look like on a CT if it's progressed. You can see the huge distal stomach. That's a real bad thing. Better get that thing drained. So when you reoperate on patients who do have a leak, you have to use damage control mentality. You are not going to fix it perfectly. You do try to fix it if you can. The tissue's probably not going to hold your stitches, and you have to assume that whatever you do is going to leak again. So you've got to put lots of drains in, provide enteral access, and batten down the hatches. You're going to be in for a long course. And you only really do anything major. The only time you would be warranted to resect anything or revise an anastomosis and so forth is if the situation dictates it by ischemia, something's clinically ischemic or necrotic or something like that. But you don't want to do more than you have to. There's been a number of literature articles on observing leaks, and I can tell you that it's not the standard of care. If you do it, you have to be very careful. And you have to, the tenet should be that the patient should be stable, the leaks should be documented to be well drained, and they should continue to do well with just antibiotics and drainage. So what is the actual leak rate? Well, Matt Hutter looked at the BSCN database, presented this, published in the Annals, and it showed that the leak rate for that database for gastric bypass laparoscopically is under 1% and about 1.5% open. And causing reoperation. So there's 2 data points here. The one is this data, but notice that most people still, and they should, are reoperating on these patients. Those numbers are very similar, so very few leaks were observed. So what about strictures? Strictures after bypass, I'm going to define a stricture for this talk as basically the proximal anastomosis. Distal to that's going to be defined as a bowel obstruction, and they're going to be classified differently, and you really can't kind of treat them the same. So I'm going to talk about strictures of the proximal anastomosis. The literature report is anywhere from 2 to 18%. Most series are in the 5 to 10% range. They usually present about 1 to 3 months post-op, the typical ones. The usual ones that occur at 3 to 8 weeks are from stenosis, from edema and swelling. They usually do not have a marginal ulcer with them. The patients give you a history of, well, a week ago I was eating my semi-soft food, and then last week I could only take in liquids, and now I can't eat anything, so that I'm kind of having trouble, and that they come in, they've got stenosis. You can see from these data that marginal ulcers are associated with ones that occur later, and that makes sense because that's what causes the stenosis in those situations. How do you manage them? Well, I think if you have a patient you suspect has a stenosis, you should scope them. Because if you scope them, you can then therapeutically dilate them at the same time. If you get an upper GI series, you find out they're stenotic, you still have to go and scope them and dilate them. So I usually do endoscopy as the first-line test. It may require a second or third dilatation. Don't be discouraged if the first one doesn't work. But if the second one doesn't work, I think you have to think about why and go look for etiologies. Because usually the data in the literature show that most of the time you can get these folks open with about 2 dilatations. I've used fluoroscopy in our institution. They do have a little bit better stretch to some of their balloons than we do endoscopically. We used to have now we have larger endoscopic balloons, but the smaller ones before weren't as big. And I only operate on these folks if they have a marginal ulcer. That's what it looks like endoscopically. Typically, when you look in there, there's just a pinhole, and you got to get your dilator in and do that. You have to be careful, though, with these that that's a hole, but you don't see the back, and you can, if you blindly put a dilator through there, you can go through the back wall of the jejunum if you're not careful. So you have to be kind of careful about dilating these folks. And I dilate them if the endoscope can't fit through. they've got vomiting, and they obviously have stenosis, and you can't pass the scope. You want to use an 18 to 20 French balloon, dilate it under direct visualization, and then get it to the point where you can get the scope through. And here just shows the dilatation. So, all right, in our early experience when we looked at and kept track of these, we've had about 9.6% stenosis rate. We dilated, we treated those patients, of the 54 patients with 80 dilatations, 94% of whom were successfully dilated and didn't need any surgery. And that's about 10 years old now, this article, and only 3 out of the 54 patients actually had to get reoperation. Other data from other series, I'll just go through these quickly. Large series, again, 500 patients, average number of dilatations, 2.1. 30% required more than 3, and the success rate 95%. Another series, 1,291 patients with a 7.3% stenosis rate. Again, successfully dilated in most cases, only 2 perforations. And these perforations, again, I can tell you that's because they put the dilator through the back wall of the jejunum. 1,400 patients, 1,345 sutured gastric bypass from Fresno. And that group showed that they were successfully balloon dilated just about all the time. Second dilatation required and a mean of 1 to 1.2 times.
We present a case of a laparoscopic proximal gastrectomy and worldwide reconstruction for a patient with a chronic staple and disruption after gastric bypass or morbid obesity. This is a 41-year-old male with a 9-month history of gastrocutaneous fistula, recurrent abscesses, back and shoulder pain, on TPN that presents for surgery after having a
what is the stricture rate, again, from the
empyema drained biothoracoscopy. The procedure is begun on the right side of the GE junction, identifying the right crus of the diaphragm. Once the right crus of the diaphragm is clearly visualized, we'll proceed in moving towards the left upper quadrant by taking down the frontoesophageal membrane.
Likely, I think, due to anastomotic
Once the frontoesophageal membrane is taken down, as you can see here, we can identify the esophagus. An EWAL tube will be placed to identify the esophagus, and a window dissected behind the esophagus to the left upper quadrant abdomen.
You're probably not. And that's been
the procedure is then carried out by taking down the left gastric artery with the means of a wide cartridge linear stapler. Here you can see how we're accessing the area of the fistula. Going into the abdominal cavity, you can see non-absorbable sutures left behind that are usually one of the reasons for these fistula tracts.
And the
harmonic scalpel is used for that purpose.
I can tell you,
in a series of approximately 18 of these cases, we have not had to take down the spleen.
And it still works.
Here you can see the opening.
So, stenosis is nearly preventable. If you're not using a linear stapler, I would encourage you to try it and do it, because you will not be spending your time in the endoscopy suite at dilating as many patients. So in summary, for leaks, have a high index of suspicion, aggressively treat them. The site of the leak is important for how it will present, and operative treatment is the norm and the expected standard of care. For stenosis, for the proximal ones, you dilate them endoscopically. I would highly recommend using a linear rather than a circular stapler, and marginal ulcers are associated with chronic stenosis and will frequently need surgery. Thank you.